First off, let me thank you very much for this invitation. It's really fun for me to get to do this with my colleagues from different parts of the world because although my co-panelists are quite well known to this audience as experts on this topic, we realized that when we talked together that we had very different perspectives and that there were real geographic and cultural differences in this topic. So I'm excited to bring you the version that that I have thought about here in the United States. I also want to tell you that a lot of what I'm going to say today is absolutely my own opinion. It will be clear when I'm speaking which is research results and which is my own opinion, but I have no conflicts of interest to disclose. So let me give you a little bit more information about my bioethics backstory, because I think it's actually relevant to what we're talking about today. I started thinking about why veterinary practice is so emotionally difficult way back in the late 1990s when I was an emergency and critical care clinician. I spent my entire practice career of about 30 years at Angel Animal Medical Center, which is a 125-year-old veterinary hospital, the flagship hospital of the Massachusetts SPCA, that is a combination of a specialty hospital, a general veterinary practice, and a charitable hospital. And at our hospital, we see over 80,000 cases a year. But way back when I began my training there, it was obvious that certain cases, certain clients, and certain situations drained a disproportionate share of the emotional reserves from the staff. Many of these cases were labeled feudal care or non-beneficial care. And I spent a lot of time pondering over this and talking to my colleagues, and eventually started my formal training in bioethics at Harvard Medical School Center for Bioethics. My mentor, Dr. Mildred Solomon, who is the president of the Hastings Center in the United States, a bioethics think tank, did groundbreaking work around the same time that I was starting my training in the early 1990s. And this is a picture of a paper from her PhD thesis, where she and her colleagues did what was essentially the first survey of ICU physicians and nurses in the early 1990s, asking them whether or not they felt like the work that they were doing to keep human patients alive in the ICU was work that they thought was the right thing to do, and also whether or not it was the kind of care that they would want to receive for themselves. And this was the first time that people realized that healthcare providers didn't actually agree with a lot of the care that they were providing to patients. And essentially, this work happened in the context of some Supreme Court decisions in the United States that really swung the pendulum from very paternalistic medical care at the end of patients' lives to a more patient rights approach, where patients started to actually question what was happening at the end of their lives and whether or not they got the care that they wanted. So Dr. Solomon essentially asked me to recreate her work in the veterinary world. And one of the things that I realized pretty quickly was that although we were talking about things like compassion fatigue and burnout a long time ago in veterinary medicine, we weren't talking very much about the roots of the problem and how much of the roots of problems like compassion fatigue and burnout actually came from ethical conflict. So I will say, and this is clearly my opinion, that I'm still quite frustrated by our profession's insistence on looking at these problems as individual agents and individual matters that people, because I think it's so unrealistic to ignore the systemic factors of these problems, and also to expect people who are already really burdened by this to fix these problems themselves. So let me start with my definition of moral distress, which you're going to see pretty quickly when you hear from my co-panelists differs somewhat. And I think we're going to talk a little bit about that. I use Andrew Jameton's original 1984 definition, which came out of the nursing literature. Most of the moral distress literature, which is quite broad and deep and rich, comes out of the world of nursing for, I think, fairly obvious reasons. Jameton's original definition said the experience of knowing the right thing to do while being in a situation in which it is nearly impossible to do it. So what you should know about this is that there's a lot of arguing going on among bioethicists, philosophers, healthcare providers about whether or not this definition needs to be enlarged to include also the negative feelings that are produced when you don't know what the right thing is to do, not just when you can't do the right thing. I tend to lump both of those definitions together when I think about this and when I do work on this. But there's a few other important pieces that I think really resonate for the veterinary field. One is it's important to remember that this is different from other kinds of work stress because it involves an ethical conflict. Another thing that I learned in my training, which I really didn't understand, is that the impacts of moral distress are cumulative. And I think veterinarians are really good at compartmentalizing this stuff. And it was quite an eye-opener to me to realize that compartmentalization might actually be more damaging than we think and not as great of a solution because the impacts are cumulative. Another potentially expanded definition of moral distress includes the idea of moral residue, which I think is another concept that really may hold a lot of weight for the veterinary profession. This concept came from Anne Hambrick, who is a real leader in the field of moral distress research. And what she meant by the idea of moral residue is the feelings that are produced when you do what you believe to be the right thing to do, but you still feel bad. And I think that that veterinary professionals can really relate to that. I think euthanasia is a great example of why we might have moral residue. But why? Why is this such a big problem for veterinarians and, of course, for the rest of the veterinary healthcare team? Well, there are some really good reasons. One is, compared to our physician counterparts, we're exposed to critical incidents 5 times more often. That's a big deal. And we know that that's a serious risk factor. We face frequent ethical dilemmas, and particularly here in the US, most of the people that I surveyed in my research did not have any training in ethical reasoning or communication. We also, of course, know that veterinary nurses or veterinary technicians, as we call them here in the United States, are likely at much higher risk than veterinarians are. And I think that makes sense because all of the same problems are compounded by maybe bigger feelings of helplessness or powerlessness when your role is not necessarily part of the medical decision-making team that happens between an owner and a veterinarian, but you're the one being asked to actually provide the care. So back in 2017, I undertook some work to document the existence of moral distress in veterinary medicine in North America. And interestingly, even though we, of course, all knew that it existed, it hadn't really been documented. So that was the original goal of this research. And we received almost 900 responses from an anonymous online survey. And a lot of the results were completely unsurprising to me. There were a few things that were surprising that I want to talk a little bit about. But some of the things that were really unsurprising to me was that the vast majority of respondents reported having conflicts with owners over what was the right thing to do. a lot of them, more than half of them, said that they had been asked to do something in practice that they thought was the wrong thing to do. And the vast majority of them reported being asked to provide fetal care. Here's what was really surprising to me. One was many people who responded in free text format said that they didn't consider financial constraints to care as being an ethical problem. And that to me was pretty stunning. And I think it says a lot about how common financial constraints to care are in our everyday practice life, that we have gotten to a point where we don't even see that as a ethical conflict anymore. The other thing that was really surprising to me was that most veterinarians reported that cases of so-called fetal care caused them and their staff more distress than inappropriate requests for euthanasia and financial constraints to care. So that led to this work in progress, which we presented to the American Society of Bioethics and Humanities a few months ago this fall, to an audience of all bioethicists, most of whom were physicians, many of whom were pediatric bioethicists and pediatric palliative care specialists. And by the way, more than half of my practice life was in pain medicine and palliative care. So that's where my training comes from. And it was a really interesting discussion to have with physicians, because it's very hard for physicians to wrap their head around the fact that veterinarians don't have what to me seems like the luxury of always putting our patient's best interest first. So let me tell you a little bit more about this work in progress. The goal of our study was really to, first off, figure out how do veterinarians define futility and fetal care. We knew from our original literature review that just like in human healthcare, there certainly was no consensus definition about what fetal care is. So we surveyed over 500 veterinarians in North America. Almost all of them were in the United States. And even though we tried in vain to capture non-veterinary members of the healthcare team, we were largely unable to do so. And I'll talk more a little bit about this in the limitations section. What we wanted to know is, besides how they define fetal care, how often do they encounter it? What are their beliefs and attitudes about it? And what kind of contextual factors influence whether or not they actually provide care that they consider fetal but an owner asked for? So what we found is, no surprise, there is no consensus definition. What was clear is that we're only talking about fetal care from the veterinarian's point of view, not from the patient's point of view, and not from the owner's point of view. About half of our respondents defined futility as providing care that is unlikely to help with recovery or to have a desired goal in meeting some physiologic benefit. So right away, you can see that's a pretty clinical definition. But on the other hand, almost 40% defined it as being uncontrolled or permanent suffering and disability. So we know that we're not talking about the same thing, and that really complicates matters. Another thing that is really interesting to me, in having seen the wonderful literature coming from the UK and the rest of the world, other than the United States, is that in the United States, we don't talk about overtreatment the way the conversation seems to be happening in other parts of the veterinary profession. And I don't know really why that is, but nobody really in the United States is talking about the concept of overtreatment. And I'm wondering whether or not that would actually change the conversation for us somewhat. The vast majority of our respondents encountered fetal care often within the last year of their practice life, and also the vast majority of them provide fetal care. And almost all of them believe that sometimes it's the right thing to do especially for owners. So lastly, I just want to say that there were some very important limitations of the results that we got. And we are thinking hard about how we're going to proceed from this point. One of them, as I mentioned, is that most of the people who responded to our survey were veterinary specialists, largely emergency and critical care clinicians and internal medicine specialists from all different disciplines. Very few of our respondents were general practitioners. The other thing was the lack of our ability to capture the veterinary technicians, the veterinary nurses. And the real reason I think for that is that within the United States, veterinary technicians do not generally belong to a large national organization, and regulations are done state by state. So it's very hard to find and reach large numbers of veterinary technicians here in the US. One of the questions that the other thing that I should mention is that we collected this data during the first couple of months of the pandemic. It was before things really started to get ramped up. It was in February and March at the beginning of the pandemic. So there were impacts on the way people were practicing, but nothing like happened that you're going to hear about from my colleague, Dr. Quain. So we are also considering, of course, redoing our data collection sometime in the future when we're not in this situation. The question that I really, really want to answer that I'm not quite sure how we're going to be able to do this is whether or not veterinarians ever believe that fetal care benefits their patients. It's clear that some physicians believe that fetal care is of some benefit, even if we call it non-beneficial care, to their patients. And largely that's about emotional state and family relationships. So I'd be very curious to hear whether or not veterinarians feel the same thing. And I'm looking forward to hearing from my colleagues and you responding to whatever comments you have. Thank you.